starting with the crucial role of high quality pathology. So there has been this idea that the incidence of triple negative breast cancer is much higher in the African continent, but more recent studies have shown that it is not as high as we initially thought, but that those initial very high incidence had to do with the quality of pathology, leading to more ER and PR negativity than it really exists. So emphasizing how crucial it is, all the pre-analytic and the analytical phase of the pathology and analysis and correct characterization of the breast cancer subtype. So a second important point is to know that triple negatives is a very heterogeneous bag of tumors. First of all, we should exclude all those that are not ductal or from ductal histology, and this special subtypes have a different type of prognosis even. And within the ductal histology, there's a heterogeneity, but so far the subgroups that have been researched, we are not ready yet to use in clinical practice. So in practical terms, what we need is a good quality evaluation of ER, PR, HER2, and if possible and accessible, germline BRCA mutation and PD-L1 status, particularly for the metastatic setting. It is not recommended to do multi-gene NGS panels. For the management of early triple negative breast cancer, the main take-home message is that chemotherapy is the mainstay of treatment. Preferably, it should be used in the neoadjuvant setting, but that means that you have to have a very good multidisciplinary setting organized. The type of regimen, the standard type of regimen is anthracyclins followed by taxanes. In very high-risk tumors, platinum may be added, but this adds also toxicity, namely fertility, and these are usually very young women. There are data showing that post-neoadjuvant capecitabine improves survival, and there is an emergent role for the use of pembrolizumab and nolaparib in the adjuvant setting, but the big problem of these two targeted agents is their extremely high cost, make it unavailable for the vast majority of patients in the African continent. For the management of triple negative breast cancer, the main take-home message is that chemotherapy remains the mainstay of treatment, and single agent used sequentially is the best approach. There's no benefit in survival in giving combination chemotherapy, no problem in reducing the dose, adapting to the toxicity, leading to a good balance between quality and quantity of life. And if possible, prefer oral therapies if accessible. For example, metronomic CM is inexpensive and very active in this setting. There are three types of targeted therapy: the checkpoint inhibitors, the PARP inhibitors, and the antibody drug conjugate sacituzumab govitecan, but all of them are very highly costly and again, almost not accessible for all patients in the African continent. So for the first time, we have started to see some overall survival benefit in the metastatic setting, but for that we need access to these new therapies, and this is something we all need to fight for the African patients. The other participation in the aortic conference from the ABC Global Alliance was the organization of a communication skills workshop, where we discuss how can we improve our communication using all these virtual technologies that we are using since the pandemic has hit us quite hard, but also learning how to best approach communication in the advanced cancer setting from presentation or informing the patient about the relapse or of the presence of metastases, and until discussions about palliative care and end-of-life care with both the patient and the caregivers and the family, respecting very specific cultural differences and social differences in the different countries. So Professor Fran Boyle from Australia has led this communication training workshop, guiding the participants through the SPIPES protocol, and many of our collaborators in different countries in Africa provided examples in clinical practice on important issues and specific issues in African countries. One last word to guide you to the Advanced Breast Cancer Global Alliance website, where you can find resources freely available that is called a toolkit for hard to reach communities. So isolated communities, rural communities, low socioeconomic setting, where you can find projects that many of them implemented in Africa to better aid, to better provide aid to this type of patients. And also invite you to have a look at our awareness campaign video, one about stigma and one about working rights and working needs of patients with advanced breast cancer. So please join our website, use our resources, and if your organization is dedicated to advanced breast cancer, please join the Advanced Breast Cancer Global Alliance. Thank you very much for listening.